Well, good afternoon, everybody. Thank you all for joining us. I kind of expected we would have a good turnout because we are still very much in the midst of a mental health care crisis, both in terms of how many kids are suffering and in terms of how hard it is to get the care that they need. So I'm really pleased and honored to welcome John Straus and Renzymeir Baloran today to kick off our mental health series with support from the PMHCA grant. We are just so pleased to be able to continue talking about ways that we can help kids to access the care that they need while we continue to work, obviously, on workforce development on not we, me personally, but we, the world of people who recognize this as a problem. So I'm going to let each of our speakers introduce themselves. As always, I will interrupt with questions that pop up in the chat if they're kind of like right in the moment questions. And then if there are bigger topics to talk about afterwards, hopefully we'll have a little bit of time for conversation afterwards. And for those of you who are clinicians, if you have any patients that you want to kind of talk about how could they access these resources or what might be helpful to them or to you to know as a clinician taking care of them, then those are also great questions to save until the end. Thank you, everybody. Go ahead.
I guess I'll start and then Renzy will follow. So my name's John Straus. I'm actually a general pediatrician. I was in practice for 25 years, and my second part of my career, the last 25 years, has really been around helping improve mental health care of kids. And let me bring up I'll bring up my first slide. Take me a minute to get here, I think. Can everybody see that okay?
Looks great.
Okay, so in addition to being the pediatrician and actually working for, I'm partially retired now, but I had been working for the last 25 years for a managed care company. I have had the pleasure of starting the Massachusetts Child Psychiatry Access Program, FAAP, which we'll be talking about tonight, 18 years ago. And in the process, discovered that this was really a great tool for people, pediatric primary care clinicians. And it slowly expanded from state to state and then became federally funded. And in 2018, and Hawaii has gotten one of those grants. So the names we'll sort of be throwing around is CPAP, the Child Psychiatry Access Program, which is sort of the generic name. And then the very specific federally funded programs are called PMHCA, Pediatric Mental Health Child Access Programs. And as the programs have grown, we've formed a national network called the National Network of Child Psychiatry Access Programs, for which I'm president, and we'll talk a little bit more about that as we go along. Okay, so just a little bit about, whoops, I'm having to figure out where so I can see the slides there. All right, so why a consultation program for PCCs? I don't think any of you, probably most of you, I assume, are in primary care practice. It'd be nice if we sort of went around, but I think we may have more people than we can do to do that. But as you know, there are not enough child psychiatrists, even APRNs, advanced practice nurses, and PCCs need to manage many behavioral health conditions in their office, because 20% of youth have a behavioral condition. And we know that only 33% of those get identified and treated. And if we depended just on child psychiatrists, that would never happen. We've really had a revolution in telehealth services, and that's really made these programs very doable. Most importantly, if we can free up the child psychiatrists from managing mild to moderate conditions, they really can spend their time addressing the more complex conditions that really help them practice, as people say, at the top of your license. More and more practices are having integrated behavioral clinicians, usually a social worker, almost never a physician or a child psychiatrist, so that we need to help with the medical components along with the therapy. And then we're going to talk a little bit about collaborative care, because increasingly, to do good behavioral health care that gets good outcomes, you need to sort of follow that, what we call the collaborative care model. So as I go along, please let me know if you have questions, and raise your hand or put it in the chat so we can, I'd be happy to start. I'm not going to have a full, I think plenty of time for questions. Okay, so the next couple slides I'm going to cover are actually taken from the American Academy of Pediatrics, as you know, pediatric practices, and when I say pediatric practice, I mean those with pediatricians, nurse practitioners, family medicine docs, and medicine nurse practitioners or PAs. So anyone who's in the primary care space. Excuse me. And in a pediatric office, we're caring for kids from prenatally all the way through adolescence. We really understand behavioral health within the context of a continuum, and we understand the social drivers of health. We're the medical home. We can deal with stigma. We have community. We know the community resources. We know what's available in terms of education and childcare, the economic resources, relationships with families, cultural issues, issues around racism, trauma, anxiety, suicide, substance use. So we really can cover the whole gamut of issues, but there are times when we're not sure what to do. And that's where we hope access programs will come in. And sort of following up on that, why pediatric primary care are we focusing on doing this? Well, we have the longitudinal relationship with families, so we get to know them. We have a developmental perspective. We are seeing kids regularly, so we can identify and intervene early. We have a relationship with the parents, so we can support parenting behaviors. We have a nurturing, stable relationship with families. Again, we know they know us, we know them, and we can serve as a trusted source of information. I hope I'm not, these last few slides are not new to anybody. And continuing that mental health development framework, we can help the families understand that mental health is not an illness to be treated, but a development process that occurs across the lifespan. Unfortunately, some people will have more complex illness, but almost everyone goes through a phase or time when they have a behavioral health concern. And we understand about trauma and relational health, so we can see issues through that lens to promote social emotional wellness. And finally, by bringing more and more behavioral health into the primary care space, we really normalize the discussion of behavioral health issues. We reduce the stigma. We model that our office is a place for families to come if they have behavioral health concerns. As many of you probably know, the Surgeon General and the academies of pediatrics and psychiatry made it so that we declared a national emergency in terms of child and adolescent mental health about a year ago. And really, I don't need to tell you that not only even before, obviously, you're dealing with, many of you are dealing with the aftermath of the fires in Maui, but even before that, the pandemic and all, we've seen a great increase in child mental health issues. 20% of kids have a diagnosable mental health disorder, but another 19% have symptoms that may not reach the criteria to have an official diagnosis, but still are impairing and we can be helpful for too. Suicide is the leading cause of death between 10 and 24. Adults who have a childhood mental health disorder are six times the odds of having an adverse adult outcome, and the other way around, of adults with mental health disorders, 50% started by age 14. We know that the earlier we intervene with those folks, the better their adult success will be. So let me just stop there and see if there are any questions about sort of the background, and I hope it's not clear to everybody that this is that we're talking about an issue that, as Maya said, that affects everyone in practice and many of our members. Any questions so far?
No questions in the chat right now.
Okay.
I think,
problem.
you know, we're all very much in agreement with everything that you said, and we see it daily. So we're
Yeah.
so glad to have some hopefully progress towards some really meaningful solutions.
That's great. Well, that's what we're going to get to next. So for a minute, I'm going to talk from the 20,000-foot level nationally. Brad Stein back in 2019 did a wonderful study where he used the National Survey of Children's Health, and which was done that he had access to surveys that were done from 2003, 7, 11, and 16. And what he found is that states that had these kind of programs, when they questioned families, 12% of families said that they had access to behavioral health in the last year, but without a CPAP, only 9.5. So that really speaks to these programs creating access. We're not going to be the solution for everybody, and there are lots of things that go into making good outcomes. But the first step is getting in the door and being able to help families find services. So this is really was very rewarding to see. And then here's a map done last June that shows all the states that do have. Now, this is a map done by HRSA, so it's just those states that have federal funding with the PMHCA programs. Actually, since then, Utah, South Dakota, Ohio have joined the HRSA funding, as well as Guam. And but Oregon, Pennsylvania, Texas, and Arizona have programs that are funded by this within the state, so that the only state without a program at the moment is Idaho. Sorry. I have to wait for a minute to answering. Okay, so this is obviously a program. These programs do seem to be helpful, and more people are developing them, as we're happy to see is happening in Hawaii. So what are the goals of the programs? Obviously, the primary goal is to give you help when you need it, but we really want to see that everyone is using standardized screens at well child visits. So you're screening the whole population. You're understanding how to do an assessment after the positive screen or when a family comes in with a complaint. You can manage what kind of treatment the child needs. You can make appropriate referrals when you need it. And maybe above all, we want to decrease that stigma so the families really feel comfortable raising behavioral health issues within your setting. The other real goal is, as I mentioned before, there are very few child psychiatrists, and we want to balance the specialty primary care balance, so that there's a nice balance between those problems that go to the specialist versus primary care. And I like to compare it as a pediatrician to asthma. We know that most kids with asthma get treated in the primary care office. If we depended upon pulmonologists to treat asthma, we'd be in big trouble. And the balance between primary care and pulmonology is probably about the same as primary care and child psychiatry. And we need to keep that in mind, even as particularly because behavioral health issues are even more common than asthma. Okay, I like to think about these programs as in terms of a stool. Some people call it a four-legged stool, and here I have it 3 legs with a seat. And because the seat is really the key to this, which is that you're able to get a helpful person on the phone when you need it, usually within 30 minutes during business hours. It's not a crisis service, so it is, though we will certainly help everyone understand what to do in crises with a crisis situation. But the phone consultation is the main piece of the stool. And then the supporting that are help with resources and referrals, the ability to do a face-to-face or teleconsultation with the child and family when necessary, and we'll talk about that more. And then all sorts of different kinds of education, such as echoes like we're doing today, but eventually website, a newsletter, coming out with guidelines, right now, one of the best programs that has the best guidebook for PCCs is Virginia. And if you go to the VMAP Virginia website, you can find that guidebook. So here's a diagram of a little bit how the programs work. You're in your office and you got a question, pick up the telephone. Actually, you don't probably pick up a telephone anymore. You punch your cell phone, right? Many people probably have not even used one of these things, right? Anyway, and you can get the main thing. You're going to get usually you get a care coordinator or answering the phone who triages you usually to the psychiatrist who takes your call and answers your discusses with you the case and what might be the best solution. And but sometimes there's a child therapist on the team who can take many calls that, particularly those that don't need medicine, and for young kids under 6. You may, in fact, talk directly with the care coordinator who will help you with resource and referral. The child psychiatrist can give you advice over the phone, but upon occasion may decide that, and we'll talk a little bit more of the reasons for that, may actually think that best to do a face-to-face with the family and child. And we try and keep to a 2-week waiting list time, that oftentimes less. So we're just, it's a one-time consult. So we're not backlogged. We don't end up doing treatment. We're just trying to figure out what is the best thing that you as a primary care clinician can do to help the family.
Dr. Straus, we do have a question in the
Yes.
could you confirm the web address for us, because someone tried the mcpap.org and got an error message.
mcpap.org should work.
Okay. Well, just yeah.
If it doesn't, something's happened just recently, because I was on a little while ago. It was working.
I wonder if it's down because I'm not on like a hospital network and I'm getting the same error message. So it might just be that the website is currently down.
All right, I can check. I won't do it right now, but
yeah, I'll search a little bit more while you're talking and see if I Google it and kind of follow a separate link or something.
Okay. And
right.
The other website that's useful is nncpap.org. Oh, you know what? It's mcpap.com. I think try that. That probably will work.
While we have you, can you clarify, like while we took a pause here, can you clarify when you say face-to-face psychiatric consultation, is that for the PCP to like have a longer conversation with the psychiatrist, or is it for the PCP and the patient, or just the patient to talk to that psychiatrist?
It's usually just with the patient. We're very happy if the PCP wants to join in. It didn't used to be possible, but on Zoom that could be done. But most of the time, the PCP doesn't want to spend that kind of time. So it really is, and we'll talk about the PCP gets back. It's a formal consultation, so the PCP gets back a consultation letter, and usually we have a telephone conversation after the visit to review what should be done next.
Oh, and having that communication. So in the Hawaii AAP has been working too on sort of expanding access to behavioral health resources for kids and adolescents. And one of the things that came up at our recent meeting was that a lot of so I'm a hospitalist, so I don't have this experience, but a lot of the community pediatricians were sharing that they refer to behavioral health and then they don't get a lot of information back. So they are still providing the primary care for the patient, but they don't have actually a lot of idea of what's going on, except for like getting that information from the patient or parent themselves. So having that like kind of system in place for a summary of the recommendations sounds like it would be incredibly valuable for folks on our end as well.
Now, again, we'll talk a little bit more about that, but this is that communication issue is still going to be true with some of the more complex kids that are in the mental health system, and that doesn't, I don't think all across the country that's an issue with not getting good communication back to primary care, especially kids in the hospital, in a psych hospital. So we're not going to solve that problem with this, but at least
it's a step, it sounds like.
It's a step, and at least you can call. Well, let me keep that question in mind as we go on, because I think that will give you some things that will, these programs do help that problem, but not as well as maybe we would like, but they're a good step. And then for any of these folks in this process, if usually it's around therapy, we keep active lists of therapists that are available and try and help families find either by giving resources to the primary care or actually talking with the family and trying to, our care coordinator sometimes has to make 20 calls to find someone that's available, but we have that service and families aren't going to really get frustrated doing 20 calls. We're paid to do that. So we do that and it really does help. It's amazing how if you're persistent enough, you can find a therapist. So let me go, now I'm going to go through each of these sort of services a little bit. And so when we're doing that phone consult, we really want to be helpful on every call. There's no wrong door. We want to make sure that whatever you're calling it and having a question about, we can do something to help. We want to make sure no question is too dumb. Everyone is in different places in their learning how to deal with mental health and substance use issues. We are mentoring and coaching. You'll get to know the people you call. Some of a bigger state will have several teams, so you'll just know the people on your own team locally. For a state the size of Hawaii, you'll probably have one team, but you'll get to know the 3 or 4 people that are working on the team. Obviously resource and referral. We really tailor our education to where folks are at, and we want to minimize the barrier for the PCC. So we don't ask, you don't have to fill out a long questionnaire. Usually, oftentimes your office staff will set up the call because we'll need to know the name of the patient and the birth date and gender and racial ethnicity. But we try and keep the information to a real minimum and address or zip code. Okay. And again, for face-to-face, it's often, reasons may be to figure out what's going on so we can know whether or not the care, at least at the medical level, prescribing level, can be managed in the office, or maybe what kind of therapist would be best, or how to use the mental health system to best serve that child. There may be a medication question. Often it's for reassurance to you guys that you can do this, that this is not beyond your scope. Sometimes it's reassurance to the family who says, my problems, my kids needs to see a psychiatrist, not just a PCC, and they do get to see the psychiatrist, and the psychiatrist can say, Prozac can easily be prescribed by your PCC. You don't need to see a psychiatrist for that. And then we are increasingly doing second opinions, and that gets a little bit to the question about the fact that there's poor communication with some of the more complex, sicker children who the families often come in when they have for the well child visit and their physical is fine, but the parent is not very happy with the care people they're seeing for their mental health care. And it's often because, unfortunately, there's a segment of kids who aren't going to get better, who are going to go on to adult mental illness, and that starts in childhood. And having a family adjust to that, our service can really help a family come to face the reality that their child is going to have long-term issues. And then bridging, we'll do a visit with someone getting out of the hospital and doesn't have a follow-up visit right away. If there's a question, we can actually not only help the PCC, we could see that person for a one-time visit and guide the PCP in what to do. And when we see somebody, or either, and usually these days over telehealth, we follow that with a consult letter within 48 hours. And most programs do formal consultations. Rather than just sort of a pointed answer the question, but from a medical legal question point of view, once you do a face-to-face visit, you really have to do a full visit. Whereas on the phone, there's not a medical legal risk, and because we don't have a doctor-patient relationship, so we can just answer the question as efficiently as possible. And again, as I said, this is really an educational program, because we want you to, the old adage that if we just tell you what to do, you'll, if we fish for somebody, then you're not, then you're not going to be able to continue to feed your family. But if we teach you to fish, then you can feed your family. So it's really a teaching program, so that once you learn how to do things and people get the more and more sophisticated, we're not trying to make people into psychiatrists, because there clearly are areas, kids that do need psychiatry. But we think we can move that balance a lot more towards primary care. And so whether it's through screening information about screening tools, toolkits, doing teaching clinical things through echoes or brown bag lunches, helping with understanding the mental health system, providing clinical guidelines and clinical pearls, helping with transferring your practice as we integrate more and more behavioral health into the practice, providing case rounds, supporting case rounds are often these days helping support the provider mental health as much as the patient mental health, and often webinars. And so I'm sorry, I think the site mcpap.org is not working, but mcpap.com definitely is.
Yeah, multiple people tried it, so it's good.
Yeah.
Thank you.
Sorry. So each team in general has an FTE of child psychiatry, and that's usually a couple people, because no one's going to do it. Our service usually is 9 to 5, Monday through Friday. It's it's usually going to be 3 to 5 people sharing each taking a slice of time. There's usually a behavioral health clinician and a care coordinator. And this is for 300,000 youth. And guess what? Hawaii has 300,000 youth. As the programs grow, we add additional services, particularly some specialty kind of services, postpartum depression, helping moms, perinatal care. For those that I'm sure many of you are beginning to screen for postpartum depression. There are now access programs, perinatal access programs, because 2/3 of women who get, or birthing individuals who get postpartum depression are identifiable before delivery, about 1/3 before conception, 1/3 during pregnancy, and 1/3 truly postpartum. So the perinatal access programs are teaching the obstetric providers to screen and treat anxiety and depression prenatally. We want to expand to early childhood. Sometimes child psychiatrists are not the best folks to early childhood. So teams are adding behavioral development pediatricians around, and that also helps with autism. And SUD, again, sometimes child psychiatrists are not the best folks to know about SUD issues, so we may well add an addiction expert. We want to make sure that we're enrolling the entire population. We're engaging all providers, and that is an ongoing process. We want to reach all practices, particularly those that may around foster kids and school-based health centers. I don't know in Hawaii about whether you have school-based health centers, but it's a popular, important provider source. I've mentioned about bridging and second opinion. We're increasingly doing consults electronically, so phone works so much better when you can talk to the person rather than playing. It's not telephone tag anymore, it's email tag. We sort of send, someone sends a question in, we send the questions back, and it goes back and forth before you finally solve it. On the phone, you can do it so much more efficiently. And then for the programs, their goal is to reach sustainability. And that means in general insurance coverage. These really are healthcare services. And in several states now, namely Massachusetts and the state of Washington, the insurers are all contributing to the support of the program. Other things that the team will have, and Renzy will talk a little bit more about what's happening in Hawaii in terms of the creation of the team, but to analyze the types of interactions that are happening, encounters, marketing and communication, both to the community as well as both the provider community and the patient community, politics so that we can get support for the programs, and usually programs will have an advisory board to help make sure that we're providing the services that are needed. Let me stop for 1 second. Any questions so far? I'm going to go a little bit into what some of the results are for these kind of programs. Okay. So when we measure PCC's feeling of competency, self-competency, they usually get very good about anxiety, depression, ADHD. We still struggle with SUD. I think it's hard. I mean, I think it's a hard area, especially with the increase in vaping and marijuana. But certainly around traditional mental health issues, we do pretty well. Here's a picture of Massachusetts and where all the practices are. And if you look across the state, we usually have 65 to 75% of all the practice uses each year. In 22, it was 66%. So it's well used. We want everybody to, behavioral health is everywhere. So we feel that we should see utilization across the state. And on average, 17 encounters per practice. And that obviously practices are different sizes, so that will vary on the number. And this is a kind of statistic we're very proud of, that 68% of the episodes of care are managed without specialty psychiatry. So most of these issues can really be managed in primary care, along with the help of a therapist. We don't, in this day and age, want to forget about equity issues. So we're openly discussing that with our staff. We are including expert consultation to our staff so that we are aware of issues that may be in our population. We're collecting race and ethnicity data so we can make sure that we're equitable in terms of services where we're reaching for the consultations, making sure our materials and our websites are recognizing the different races and ethnicities of our population. We include it now in webinars and ECHO, and we want to make sure that particularly around issues of trauma, we're asking about that during our consults. Because many of our consults are come because someone's initially tried some medication and therapy and things aren't getting better. So we're trying to figure out what are the other issues that may be keeping a child from improving. Okay. I can't see it. I'm not sure I can see a show of hands, but does the collaborative care model is how do we think people are familiar with that or not?
I think there's a good number here who would be. We can probably use a quick reminder.
Okay.
I also wanted to let you know that we have about 15 minutes left.
Okay. Okay.
Thanks.
So quickly, the collaborative care, there are a number of components, but it's really a way of dealing with behavioral health issues that has been shown to make sure that the outcomes are good. So you want an evidence-based between screening and guidelines. You want team care. You have a care manager who tracks and follows kids with who are in the collaborative care process because of their diagnosis. It's really the key is measurement based. You're using an outcome measure such as a PHQ-9 to track people over time. You're making sure through a registry that everybody is followed. You have the availability, which is where these programs come in, to have a child psychiatrist help when a case is stuck, and then you're measuring that the practice outcome is doing well. So we really want to support the collaborative care model, so providing consultation. We can join review sessions and registry review sessions, and we can consult with the integrated care manager. So as you develop your program, and Renzy will talk to you about that, we're trying not to reinvent the wheel, but there's lots of help across the country, forming coalitions. You'll hear that some of the other jurisdictions and across the Pacific will be using you guys for consultation. And in Michigan, they've made very good use where there's very few areas, more rural areas where there's very few clinicians to put clinicians in key places to help promote services. So here's my information, but that's really the end of my spiel. So Renzy, want to take over?
Thank you, Dr. Straus. So hi everyone, my name is Renzy. I am with the Department of Health, Family Health Service Division. I was hired a year ago specifically to work on this grant to and help build the this pediatric mental health care access model for Hawaii. And then if I could, Dr. Straus, if you could stop sharing screen.
Oh, I'm sorry. Yeah.
Okay, thank you. And then
All right.
So I'll be my updates are relatively quick, but so I'll skip this over, but and then so the training aspect that Dr. Straus mentions for this program, we're doing it thankfully with Project Echo, and how we're able to meet that deliverable. And so we have the upcoming presentations. I put the wrong years, but but upcoming presentations until about January. And then, but the main updates I wanted to share was the warm line aspect. I think that's the component that we've been getting the most questions on, but it's also been one of the harder components for us to do. As a state department, we don't have like the staffing to ourselves, and so we have to contract out, but that in itself was a complicated component to us doing, but we have been moving along in order to do that, and we've kind of decided that we are implementing the warm line in a like 3-phase model within the next few years. So with the focus right now with the events of the Maui wildfires, where we're trying to do a pilot for Maui County, and then as we continue on, our goal is to, of course, expand statewide, meeting all the islands, and then finally, as Dr. Straus mentioned, that we with the other HRSA recipients, there are our Pacific Basin partners who from what they've said, it would be difficult for them to do their own separate warm lines. And so it was brought to us of doing a collaborative warm line for all the Pacific Basin members. And so that is currently what we're having in the works. And then we were hoping to have a bit more of an update in terms of like actual timeline and stuff, but there was a few issues recently. But our goal is to at least have something or some more updates within the next 3 months of concrete plans, especially for the pilot for Maui. And then this past year we have done a few other components of the project. So we released with Hawaii Health Data Warehouse, we released a child and family mental health tracker to show 40 indicators related to mental health for women, children, and families in Hawaii. And we also funded the pediatric mental health track for the Hawaii Health Workforce Summit. And some upcoming things or also continuing projects that we have is we've been working in collaboration with the Hawaii American Academy of Pediatrics to do some outreach to pediatric providers in all islands. So just setting up little meetings here and there. We started it this year and we hope to continue on within the next few years. So we hope to increase our reach and reach out to more people that we haven't met yet. And the first sessions we did, we mainly asked about like what the current issues in the mental health space is for providers. But as we continue on with our deliverables, and we hope to also use these opportunities to get feedback on like the warm line or trainings that we provide, and to see more of like the needs. And then we're also trying to get a better idea of like the mental health landscape in Hawaii. So we're working with partners to do an environmental scan of the different mental health services. So we're working with the Suicide Prevention Task Force and Dr. Sugimoto from UH Office of Public Health Studies on that. We're also working with Mental Health America Hawaii to update the mental health resource list that they have on their website that gives that hasn't been updated for a couple of years. So we hope to have that and be able to offer it for those who need it. And then we've also gotten feedback in our past meetings about doing further having different formats of training opportunities. So either longer formats for those who feel like they would benefit from more longer sessions, and then also some that were interested in some in-person activities as well. And then we're also trying to in addition to trying to get a better idea of the mental health landscape in Hawaii, we're trying to convene more with different mental health stakeholders to understand different projects and events happening in Hawaii, and then be able to share that out in the wider public. I think mostly one thing I want to leave off is even if one thing our focus is, we are trying to get as much feedback as we can and talk to those that will be using and benefiting from this project most, as although we're following a model, we want to ensure that this fits the needs of Hawaii and those that we want it to be beneficial for. And so that's a big component that like we'll we will try to adjust as needed, and also like we're very open to hearing what is working from everyone and what's not, and to help us with that. And then we are very grateful for a lot of the collaborators we have that joined our advisory committee. We are trying to get as much of people who are working in the mental health space to get feedback on what we're doing and ensure that the model that we're building is beneficial to Hawaii and our members. And so we're very thankful for all those who has currently helped us with this along the way. And then, yep, and this is my contact information if anyone needs it. I'm always willing to talk more about the project and give updates as well. So thank you.
So can I just add that I've gotten to know Renzy over, I don't know, the last year, almost, maybe it's more than a year, at least a year. And you guys are very lucky that you've got Renzy trying to organize all this, because she's wonderful. So it's not easy. And I think she said something that I didn't say, which is really important, which is that healthcare is local. And if you look at all these programs across now 49 states, two Indian tribes and 4 territories, they all are a little different. And they really have come to, I must say that when I first sort of started, I thought, you just reproduce it, but it doesn't work that way. So you really have to meet the needs of the community. And I think particularly in a community that's split the way you are, the division between what you do with mild to moderate primary care versus more complex, you may well find you're helping with the more complex kids because they can't get to where they're not going to get to the Big Island for where the ideal service is. So particularly in rural areas where there's less access to the specialty services, I think you'll end up, the primary care folks end up doing a lot more. And we're here to help.
Thank you both. We have a couple of minutes for questions or to talk about what we might be able to access in the near future for our patients, for any of the primary care physicians or others who are patient facing. I also wanted to take a moment to let you know that the next session is going to be discussing CPAP interventions for early childhood. For those of you who want to see about more details about how that's been implemented, Dr. Sheila Marcus from Michigan will be sharing her experience and expertise with us next time. So I think that's a really nice flow too, from this kind of introductory overview to more specific implementation of that and how we might be able to learn from her as well as from Dr. Straus in terms of when we are telling Renzy what we need and what we think would be most helpful for our patients, to kind of get a lot of ideas from those, because I think it's often really easy to be frustrated at barriers and to struggle with what do I do? I don't know what to do. But really what I love about you, Renzy, and I've been to a lot of meetings that you've run, and so I completely agree with John that you are an amazing leader. And what I love about you is that you really are focused so concretely on solutions. And as you said, on solutions that fit our community, which is very different from other communities in different places. So please all join us for the next one. Yes, go ahead.
So when you're lucky to have Sheila, she's wonderful for your next session. And Sheila is a very unique child psychiatrist because she's equally comfortable with helping moms. So Michigan has a great perinatal program, and Sheila does calls for them as well. And so she really crosses over. One of the things we're learning is that with this increased emphasis on screening and treating during pregnancy, that word doesn't get out to the pediatric community. So we'll have moms who have been under care getting their depression, anxiety managed, and probably at some risk for how they're going to be as parents and the OB knows, but they don't tell the pediatrician. And so you're all of a sudden, the baby comes in the office and you think mom is stressed out, and you don't know that she already has really been evaluated in care and needs to continue that. And so these programs really ought to work in tandem with each other, and Michigan has done that very well.
Yeah, and I think that young children's mental health challenges are under-recognized, even as we struggle with the ways in which older children and teens, I think it is more noticeable, and you can less kind of say, oh, well, they're a little difficult, it's toddler, it's the terrible 3s and the terrible 4s, and those kind of things. And so to really address those as true issues rather than just challenges that are typical is something that I think definitely faces us all as challenges as we move forward with this. And I'm thinking, as you were talking about the mothers or the parents in particular, the birthing parents in particular, that for us in our system, and we do deliver a large proportion of the babies in this state at Kapiolani, certainly not all by any means. We use the EPIC system, and you can actually link to the mother's chart. So somebody somewhere might want to think about a quality improvement project where that was sort of integrated into the charting for the baby's discharge paperwork. A lot of our PCPs see their own babies too in the hospital, so it'll be interesting to look at how much of that is being missed, or whether maybe we already have some things in place that are good and can be improved on, as far as making sure that our PCPs are when they see a new baby do know what mom has been under treatment for, or what challenges they've been facing.
I mean, these programs, I didn't want to talk about that, but if we have a minute, they really get to be the eyes and ears of where the system is falling apart, and can really be a good vehicle to and that's why the advisory groups are very important, to take that information and try and brainstorm how you might improve that issue or lessen the barrier.
Yeah.
I mean, some things are very hard to solve, workforce, but other things can be coordination, like this. We're just talking about the communication that you can do.
Yeah. And I think all of that stuff matters, especially while, workforce expansion takes time. You have to train people, and that takes time. And we have unique challenges here in terms of training our own and keeping folks here with the high cost of living and things like that. So it's not easy. We are 1 minute over, but we can, those of us who are in charge of opening and closing the meeting can certainly stick around for a couple more minutes if folks have questions. And I know you guys are busy, so if you need to rush off to take care of your patients, we'll say a huge and warm thank you to Dr. John Straus and Ms. Renzy for sharing all that information with us. And we are really excited to have this as our first session, and looking forward to the other sessions in our mental health series. So thank you both, and we'll look forward to seeing you in a couple of weeks.
Great, thanks. I can stay on if anyone else has any questions.
A lot of thank yous coming through the chat.
And as Renzy knows, anytime you want to, if I'm actually on Hawaii's payroll at the moment, so we can have a meeting anytime you want to, if they want to brainstorm about some issues that I might have heard about a solution around the country.
Yeah, definitely. I'm sure you've been in touch with Dr. Gary Dela Cruz in that case then, because he's our mental health champion from the Hawaii AP. I wear a lot of other hats. But Gary is wonderful, and I think he's done a really good job of partnering with folks to try to get this worm line up and running. And I'm excited that you're starting in Maui. Renzy, I've been doing a lot of, you know, advocacy work with the Maui pediatricians, and you know, they are really, really struggling to keep up with the needs of their kids and families after all kinds of needs, mental health needs, practical needs, diapers, food, you know, childcare. I mean, all of it. It's been just so hard.
Yeah, from our past meetings with them, I mean, I know it was already hard navigating mental health before
Yeah.
this happened, and even more so now. So
Mhm.
we hope we could help them, and we're trying to like do as much as we can quicker so that
Mhm.
they benefit from it.
Yeah, that's great. Well,
And
thank you. Oh,
you've
go
got
on.
you've got Heather Forkey coming, not the next session, but the session after that, and she's excuse me, she's really excellent around how pediatricians can deal with trauma and effects of trauma, both on their patients, but also around their own needs.
Yeah. I know there are folks working on trauma-informed care and sort of expanding education to like what that is and how to actually do it rather than just define it. And
Yeah.
yeah. So, well, good. What a great talk.
All right.
Thank you guys so much.
Thank
Have
you.
a wonderful rest of your day.
Thank you, you
Thanks.
guys. Thanks, everyone.
Bye.
Bye.